Honored and thrilled to introduce Professor Sunil B. Rao. Dr. Rao, welcome. We are really excited to have you here and really honored despite your very busy schedule. Next time, we'll try to see if we can invite you and have you here in person. Dr. Rao is Deputy Director of the Leon H. Charney Division of Cardiology and Professor of Medicine in NYU Grossman School of Medicine. He's also the Director of Interventional Cardiology at NYU Langone Health System, New York. He had graduated from Miami University in Oxford and subsequently went to the Ohio State University College of Medicine in Columbus, where he won the David Saylor Memorial Award for Cardiology Research. He completed his residency in internal medicine and fellowship in cardiology and interventional cardiology at Duke University Medical Center in Durham. He served as the chief fellow at the Duke Clinical Research Institute, where he was the Warren and Gloria A. Newman Fellow in Interventional Cardiology. After his training, he joined the faculty at Duke, where he rose from the ranks of assistant professor of medicine to become full professor of medicine in 2017. He also became the director of the cardiac cath labs at the Durham Veterans Administration. And in 2014, he was appointed as the chief of cardiology at Durham's Veteran Affairs. Dr. Rao has distinguished career with several awards as an attending physician, including the William Proctor Harvey Award from the American College of Cardiology, the Duke Cardiology Fellows Mentoring Award, and the Duke Clinical Research Institute Robert M. Califf Award for Fellow Mentoring in 2020. In 2022, he was recruited to be the Director for Interventional Cardiology at NYU Langone. Dr. Rao has published over 500 peer-reviewed manuscripts. His main areas of interest have been in pharmacological and interventional therapies for acute coronary syndrome, as well as bleeding and blood transfusion complications among patients with ischemic heart disease. He has been principal investigator of several randomized clinical trials, including the first registry-based randomized trial performed in United States called as the SAFE PCI for Women, which compared radial and femoral approaches. And he has been a big proponent of the radial approach in coronary intervention. He has also been involved with the MINT trial, and Dr. Carson, who is here, joined us mentioned that he was an avid investigator in the clinical trial. He has been co-investigator also on the ACC-funded National Cardiovascular Data Registry. Most importantly, at the national level, he has several distinguished roles. Specifically, he's the editor-in-chief of Circulation Cardiovascular Intervention and the premier interventional journal of American Heart Association flagship. He was the chair of the SCI. He was also the president of the SCI 2022 and 23. And today we are really honored that he's going to tell us about his work on the ACS guidelines. He was the chair of the new guidelines of the ACS, and we're going to learn a lot from him. Thank you, Sunil, for joining us. We are really thrilled to have you and host you, and we look forward to your presentation.
Thank you. Thanks very much, Partha. Thanks so much for the very, very kind invitation. I mean, really overwhelmed to be here. And I wish I could be there in person and sort of interact with all of you. But I look forward to hearing your comments on the guidelines. And let me see if I can get this into slideshow mode. So, what I wanted to do with this presentation is take you through the guidelines and not only just the recommendations, but also a little bit of a peek under the hood as to how these guidelines are developed. And then I'll take you through some selected guidelines recommendations. I don't have any disclosures related to this particular topic, except that I was the chair of the guidelines. And any opinions that I express are not the official positions of any of these organizations. The challenge with guidelines is how do you make them interesting? Because it's really a huge document. It's over 200 pages. There are lots of tables, and I could read the tables to you, but at the end of the day, I'm not sure that I would make you any smarter about those guidelines or about the acute coronary syndrome disease space. So instead, like I said, what I'm going to try and do is give you a little bit of background around how the guidelines are developed. We'll take you through how the guidelines apply at the bedside, and I'll talk about a case. And then we'll grade ourselves to see how well our treatment strategy for the case that I'm presenting adheres to guidelines recommendations. And then we'll have time for questions. What I think is important is when you think about the guidelines, is they're certainly not new. The first set of guidelines for acute coronary syndrome were developed in 1994 by the what was then called the AHCPR, the Agency for Healthcare Policy and Research. It has now been renamed the AHRQ. But the reason that they wanted to develop guidelines was that they realized that there was really a lot of randomized trial evidence to support how patients with unstable angina should be treated. Now, if you take yourself back to the 1990s, this is before the advent of standardized order sets. It's before the electronic health record. And unfortunately, what was happening at many places was that a patient who would come in with unstable angina was being treated one way if one particular physician was on call. And then they were treated completely differently if another physician was on call. And oftentimes, what evidence-based therapies were available were not actually being applied to that particular patient, either because the physician was not familiar with them, or they felt like they probably knew better than what the actual randomized trial evidence was. So to try and standardize the treatment of unstable angina, the AHCPR commissioned this particular document, and it was led by Eugene Braunwald and Dan Mark and Bob Jones. Dan Mark is still a CCU attending at Duke, and Bob Jones, unfortunately, has passed away, but he's a cardiac surgeon at Duke. And what this document did was it established certain precedents that apply to the guidelines now. So, for example, science-based methodology. So where there was randomized trial evidence available, that trumped what expert opinion was. And that's, I think, a really, really important piece of what's carried over today. We have levels of evidence. Level one or class one recommendation is based on multiple large randomized trials. Level of evidence A is multiple randomized trials supporting that particular recommendation. Level of evidence C is expert opinion. And unfortunately, there are still some areas of how we treat patients with ACS that require expert opinion. And you can see that what I've highlighted for you is expert clinical judgment still needs to be applied when we look at guidelines. There were extensive literature searches that were performed, and we actually have a librarian that helps us with this now. And now, of course, we're implementing AI to make sure that we're not missing certain citations. And the other important piece of this was that this document underwent peer review and field review. Our ACS guidelines document that I'll talk to you about underwent 2 rounds of peer review. We got about 250 comments with each round that we had to respond to. Some guidelines are even posted for public commentary. So this history of the ACS guideline establishing these precedents applies to almost all the guideline statements that the ACC and the AHA produce, including the acute coronary syndrome one. These guidelines are a joint effort between the American Heart Association and the American College of Cardiology. Coming together, they create what's called the Joint Committee on Clinical Practice Guidelines. Full disclosure, I'm the chair-elect of this committee right now. Catherine Otto is the chair. They oversee every single guideline document, and is the committee, the Joint Committee, is integrally involved in deciding the writing committee. We now have an open call for applications for the writing committees, whereas in the past they were kind of appointed. There's also a separate peer review committee, completely separate and firewalled from the writing committee, that will peer review these documents. And then, of course, there are a tremendous number of staff members at each organization that support this process. And this process is ongoing. What I'll talk to you about in the ACS world is that the last update to the guidelines was in 2014. So more than a decade of randomized trial evidence had to be considered for this particular document. We don't want to go another decade before we update the document. So now there's actually a surveillance committee that will survey the literature. And when a certain threshold of evidence is reached, the guideline will be updated. And some recommendations will be revised, some will be carried over, and some will be eliminated. And it really depends on where the evidence takes us. We also like to invite partner organizations. So any physician specialty or APP specialty that interacts with a particular patient. So in the acute coronary syndrome space, we're talking about cardiac surgeons, we're talking about emergency room physicians, EMS personnel. The guidelines writing committee now have patients that are on the writing committee. And this is an incredibly valuable perspective that they bring. I'll give you one quick anecdote. I was involved in the 2021 revascularization guidelines. And I remember at one of the calls that we had, we were kind of getting down into the nitty gritty of the details of PCI versus CABG, having kind of an argument with our surgeons about, which actually reduces mortality, what doesn't reduce mortality. And it was actually the patient who was on the writing committee who told us, look, I've had bypass surgery 2 separate times. I've had multiple stents. At this point in my life, what I really want to do is I want to stay alive long enough to watch my grandson graduate high school and then have a quality of life that's really, really important to me. And that was really kind of an eye-opening thing where we were kind of getting mired in these p-values, thinking about how the patient really is at the center of what these guidelines documents are. For the acute coronary syndrome document, we got a little bit of heat when they were published because there were some people online who said, where are the surgeons? How come the surgeons aren't on the writing committee? Well, we actually did have two surgeons on the writing committee. One of them, Mark Rule, was a co-chair or a vice chair of the document. And then Sigrid Sandner, who's a cardiac surgeon from Europe, was one of the writing committee members. We invited the American Association of Thoracic Surgeons, the Society for Thoracic Surgeons, so AATS, STS, the American College of Emergency Physicians, the National Association of EMS Personnel, and SCAI to participate in the creation of this document. Of those five societies, the AATS and the STS never responded. So despite our invitation to them to actually collaborate on this document, they never responded to the invitation. So unfortunately, they were not one of the endorsing organizations. Instead, the ACEP, the National Association of EMS Personnel, and SCAI were endorsed and partner societies in this document, and they had representatives on the writing committee. So this is the document. I encourage you to take a look at it. I mean, I think, one of the things that we've gotten better at in the guidelines is to make them more succinct. Every section really could not exceed more than 200 words. So whereas in the past it was this really voluminous document, now it's a little bit more concise. It's a little bit more clinically friendly. We did, again, have to wrestle with the fact that we had a decade of randomized trial evidence that we had to consider. And for the first time, we combined both non-ST segment elevation MI and STEMI in the same document, which presented kind of a challenge to us. And as we embarked on this, we had to think about certain ground rules that apply to all guidelines. So the first of those ground rules is that we have to consider the randomized trial evidence and use the wording that's in the randomized trials. So for example, if there is a randomized trial that said we randomized 6-foot tall redheaded ACS patients to treatment A versus treatment B, the way we word our recommendation is in 6-foot tall redheads with ACS. I mean, we have to be very faithful to what the randomized trials are. The second thing is that if there has been a prior document, guidelines document that made a recommendation, and there's been no new randomized trial evidence to change that recommendation, we cannot change it. And this will become relevant as we start talking about mechanical circulatory support later in the talk. And we also have to decide on when we can stop considering evidence. We were given a 14-month time period or deadline to bring this document to completion. And I'm proud to say that we brought this document in on time. But you can imagine as the evidence keeps rolling, you can say, gosh, we need to include this and we need to include that. Well, we have to draw a line in the sand somewhere. And unfortunately, part of the process means that regardless of where you draw the line, there may be a new trial that you wish you could have included, but we simply can't include it. And that's why it's important that clinical judgment always be included when you're applying the guidelines to your patient. And then finally, we had to make some decisions with this particular document because back when I trained, MI was easy. I mean, there was non-Q wave and Q wave, and that's it. But now, of course, we've got 5 types of myocardial infarction. So what is this guideline relevant to? Is it relevant to all types of MI? Or is it relevant to just one type of MI? And so as a writing committee, we decided that the focus of the document would really be on type 1 MI. And the reason for that is that the randomized trials that were performed and that are included in this document made the assumption that the patients that were included had type 1 MI. Now, it's entirely possible and likely that some of those patients were type 2 MI, but the fundamental assumption was that they had type 1 when they were randomized. We also took a little bit of heat because we didn't use the occlusive MI or the OMI paradigm, which I think is starting to become even more popular. This is the Queen of Hearts model that will take an EKG and apply AI and determine whether or not a patient has an occluded MI. And again, the reason we couldn't include that classification is that the randomized trials didn't use it. As these randomized trials start incorporating those kinds of new paradigms, I suspect that they will be included in future iterations. But for the purposes of our discussion, this document is focused on type 1 myocardial infarction, still using that classic designation of ST segment elevation or no ST segment elevation. So having that as the background, let's now go to our patient. This is a 75-year-old female with a history of hypertension, type 2 diabetes, AFib, dyslipidemia, presents with NSTEMI. She has a high sensitivity to troponin that's elevated and rising. She's 59 kilograms, so she's probably very frail. She's anemic. Hemoglobin's 8.5. Creatinine clearance is quite low, creatinine of 1.6. In this particular situation, is probably a creatinine clearance close to 30. POCUS shows that she has a normal left ventricular ejection fraction and no valve disease. So let's now apply are guidelines recommendations to this particular patient. And what I'm going to talk about is something old, some things that we've carried over from prior guidelines, something new, which is really probably where the meat of the talk is, something borrowed. We did borrow some things from recent guidelines documents, and then talk about other areas that we still have a lot of work to do. So something old. What did we carry over? Well, from the 2014 guidelines, we carried over oral P2Y12 inhibitors. Really, the standard of care for patients with acute coronary syndrome is now dual antiplatelet therapy, as I'm sure all of you know. Aspirin alone is not enough. If you have availability of these newer agents, and I think almost everybody does, really a more potent P2Y12 inhibitor is recommended over clopidogrel. These are not new recommendations, so prasugrel or ticagrelor. Both prasugrel and ticagrelor have been studied in ACS patients undergoing PCI, but remember, prasugrel is really a cath lab drug that was studied in the Triton-TIMI 38 trial of patients undergoing PCI. So in that minority of patients with non-ST segment elevation ACS, who you may decide not to cath for whatever reason, maybe they're very frail, maybe their comorbid conditions prevent safe cardiac catheterization. Really, ticagrelor is recommended over prasugrel because again, prasugrel has not been studied in that setting. If you don't have either one of these available, then you should really use clopidogrel. But again, I think that's really not something that is common throughout the United States. The question, of course, is when do you give the drug? And in this context, upstream really means before the cath lab. And if you look at the landscape of ACS management in the United States, about half the centers will pre-treat. In other words, they'll give the P2Y12 before the cath lab, and the other half won't. When I was at my previous institution, Duke, we didn't preload anybody. We loaded them in the cath lab when we knew that we were going to do a PCI. Here at NYU, we preload everybody. The risk, of course, is that there is a downside. If the patient has surgical disease, they may have to wait because of the surgical bleeding risk. But the reason that upstream therapy gets a class 2B recommendation is largely because there really hasn't been a strongly positive trial of preloading with P2Y12. There's one trial called Atlantic that looked at the STEMI population that suggested a reduction in stent thrombosis. But in an era of rapid trips to the cath lab, it's very difficult to show a benefit. Mechanistically, there might be a benefit. So that's why it gets downgraded to a class 2B recommendation. Again, this is not a new recommendation, but it's been carried over from the prior guidelines. So what about antithrombin therapy? Well, again, these are carried over from the previous guidelines. These I've highlighted in green, the class 1 recommendations for parenteral anticoagulation prior to the cath lab, preferably in the ED. So fondaparinux, an indirect 10A inhibitor. I don't think anyone's really using this except for maybe Chris Granger at Duke. It's really not a cath lab drug either. So really the order of the day is unfractionated heparin, which I believe is probably the most common agent that's being used, or sub-Q enoxaparin. Sub-Q enoxaparin is a great drug for the ED. You can give the dose 1 milligram per kilogram before the labs even come back. And if the labs come back showing a creatinine clearance less than 30, you simply skip the evening dose and you can use it once a day. It's not a very popular drug in the cath lab because we can't monitor it. And so if you look at parenteral anticoagulation for PCI, the recommendations change a little bit. Fondaparinux now becomes red. It's a class 3 recommendation. We should not be using it. That's because of the risk of catheter thrombosis that was noted in both the OASIS 5 and OASIS 6 trials. Really, the drugs to use are heparin or bivalirudin. Bivalirudin gets a class 1. That's a new recommendation for primary PCI, and that's based on this trial called the BRIGHT 4 trial. Many of you are familiar with this. This is a 6,000 patient trial of ST segment elevation MI. All these patients were undergoing primary PCI, 95% radial access. This was done entirely in China. These patients were randomized to get bivalirudin with a post-procedure infusion at full dose versus unfractionated heparin alone. And in this trial, the bivalirudin with the high-dose infusion showed an absolute risk reduction of 1.3% at 30 days of all-cause death or BARC5 bleeding. It is important to note that these event rates are very, very low, but despite that, the size of the trial did show a benefit of bivalirudin with the infusion. The reason that the infusion is important is that prior trials with bivalirudin had shown an increased risk of stent thrombosis within the first 24 hours if the infusion was shut off. That's why they continued the high-dose infusion in this trial, and it did show a reduction in stent thrombosis. So those are the older recommendations that we carried over. The second set of older recommendations is the cath lab strategy. So there are two questions here. Do you take a patient to the cath lab? And when do you take them? Well, I think for the most part, these patients who have an elevated troponin really should go to the cath lab. And the timing really is dependent on how high risk they are. So if they're in shock, they've got signs and symptoms of heart failure, refractory chest pain, continued electrical instability, they should go immediately. These patients really are kind of the STEMI equivalent, and they should go directly to the cath lab within 2 hours. That's a class one recommendation. The high risk ACS patients are really defined either by a high GRACE risk score. I'm not sure that any of us are really calculating scores these days. It's really about steeply rising troponin values. These patients should really get cath prior to hospital discharge, preferably within 24 hours. And then there's this kind of gray area of intermediate risk. What's an intermediate risk NSTEMI patient? I'm not really sure. Maybe it's the patient who's got a stable troponin, or maybe it's downtrending. They're really kind of clinically stable. Those patients should probably get cath before they go home. And that's why it's a class 2A recommendation to do before hospital discharge. And then there's this vanishing group of patients, the lower risk ACS patients. This is what we would necessarily call unstable angina in the old days. In the era of high sensitivity troponins, this is really a rapidly vanishing group, but they're probably still out there. So who is this patient? Maybe this is a patient who's had prior bypass surgery or PCI. They've got a good story. They come in, but their troponins are negative, but there's probably something going on in their coronaries. The guidelines give you an out. Here, you can take them directly to the cath lab, or you can do some kind of non-invasive risk stratification. I think for most of us in 2025, it's probably a CTA that we're doing. And if the CTA suggests an abnormality, then they go to the cath lab. And so let's go back to our patient. What do we do with her? Well, we gave her aspirin and ticagrelor. It's a class one for the agents, 2B for timing, but I'm going to color this box in green. We're doing pretty well. We're going to give her IV unfractionated heparin. That's a class one recommendation. And we're going to take her to the cath lab within 24 hours. That's a class one recommendation for invasive strategy, 2A for timing. But I'm grading on a curve. So all of us, so far we're getting, green across the board. We're doing class one. Now let's go to what's new in the guidelines. And one of the things that's new is, what do we do with non-culprit disease in a patient with ST segment elevation MI? So maybe not directly relevant to the patient we're talking about, but this is an issue. And I'm sure you all are familiar with this trial, the COMPLETE trial. There were a couple of smaller randomized trials kind of looking at the feasibility of doing multi-vessel PCI in a patient with STEMI. This is really the definitive trial. I was a national coordinator for North America in this particular trial. 4,000 patients led by Shamir Mehta. When patients with ST segment elevation MI and multi-vessel CAD, after undergoing successful primary PCI to the culprit lesion, they were randomized to so-called complete revascularization or culprit-only revascularization. Now, there are a couple of caveats here that Mark Rule, the cardiac surgeon, reminded us of while we were writing the guidelines. The first is that these were patients who were deemed not to be candidates for bypass surgery based on their angiogram. Okay, so what that means is they had low complexity CAD. I think it is still important to realize that CABG may have a role in very, very complex disease, even in the STEMI patient, but this is really a PCI trial. The other thing to note is that these patients, it was not mandated by protocol that they had to have PCI at the time of primary PCI. They could have this staged, and the median time to staged PCI for non-culprit disease was about a couple of weeks here in this trial, and there was a median follow-up of 3 years. This trial showed that the complete revascularization strategy significantly reduced the risk of cardiovascular death or MI over 5 years. And it also significantly reduced the risk of cardiovascular death, new MI, or ischemia-driven revascularization. And importantly, this was angiography-driven PCI of the staged procedures. There has been some data looking at physiology versus angiography. Those trials have actually shown no benefit of physiology, surprising to all of us. Physiology clearly has a role outside the ACS setting. It's still not clear if it has a role in the ACS setting, largely because the trials have been too small to demonstrate a benefit. So in the guidelines, we said, if you've got STEMI with multivessel disease and you're hemodynamically stable, if you have very complex disease, you should consider bypass surgery. But for low complexity multivessel CAD, these patients really should undergo PCI of those non-infarct arteries after successful PCI of the infarct-related artery. And we said that it could be done either at the same time or as a staged procedure. It gets a class 2B recommendation. There is one trial called Multistars that randomized patients to at the time of primary PCI versus staged. There was a benefit of doing it all at the same time, but subsequent trials have not shown that. Plus, the benefit was all really in recurrent MI, which for those of us who've adjudicated events for trials, I can tell you there is no reliable way to look at a recurrent MI in the setting of a STEMI. So I'm not really sure that that trial is definitive, and that's why we gave it a Class 2B recommendation. What about NSTEMI? Well, we said complete revascularization is important in the NSTEMI population as well, but we gave a Class 2B to physiological assessment, again, largely based on the data that has been incomplete, not in the complete trial, but not complete data. And there is another trial that's ongoing now to address this particular question. It's called Complete 2. And this trial is randomizing over 5,000 patients with STEMI or NSTEMI with multivessel coronary disease to a physiology-guided PCIs using kind of resting indices or FFR versus angiography. This trial is about 1,000 patients enrolled, so it'll be a few years before this reports out. But I suspect this will inform future iterations of the guidelines. The other new recommendation is in cardiogenic shock. And this is an important one because this trial, the DanGer Shock trial, took 10 years to complete. 10 years to randomize 355 patients. You can imagine how difficult this was, largely because there are many investigators who don't have equipoise when faced with a patient who has cardiogenic shock, and randomizing them to MCS, mechanical circulatory support versus not, is a very, very difficult thing for some investigators to do. And I think for good reason. These patients are very sick, they're dying in front of you, and so randomizing them just, is challenging. But these investigators did it. This was started out in Denmark, and then they incorporated Germany. These patients had STEMI and cardiogenic shock. They were then randomized to standard care versus the use of the microaxial flow pump, also known as Impella CP. Now, there are a couple of things that it's important to point out about this trial. I had the privilege of writing the editorial for this study in the New England Journal. The first is that they looked not at the 30-day endpoint, but at the 6-month endpoint. And the reason is that these investigators learned from the investigators of the original shock trial. Remember, the original shock trial done in the late 1990s, 1999, I think, randomized patients with cardiogenic shock to get primary PCI versus usual care. That trial established primary PCI as the standard of care for patients in cardiogenic shock. If you go back and read that trial, the 30-day endpoint was neutral. It really wasn't until 6 months where the benefit was realized. So these investigators, the DanGer Shock investigators, learned from that and used 180 days as their primary endpoint. The other thing that they did was that they learned from the prior MCS trials, and they excluded patients who were comatose at the time of randomization. You could have cardiac arrest and be successfully resuscitated to get into this study, but you couldn't be comatose. And that's really, really important because in those patients who are persistently comatose after cardiogenic shock resuscitation, it's likely that nothing is really going to help to reverse their course. And that becomes relevant when we talk about some of the other recommendations around MCS. As all of you are aware, I'm sure, the use of the microaxial flow pump or Impella CP in these patients resulted in an absolute 13% reduction in 180-day mortality. That's a number needed to treat of 8. And if you go back and read the original shock trial, you'll see that the absolute risk reduction in mortality at 180 days with primary PCI and shock is also 13%. It's really kind of spooky how consistent these two trials are, but this benefit didn't come free. It came at a cost. And it came at a cost of increased bleeding, limb ischemia, renal replacement therapy. If you look at the distribution of deaths in the DanGer Shock trial, it's a bimodal distribution. Most of the deaths occurred within 48 hours. And then there was a later curve of death at around 30 days or later. So one argument that's been made is that the reason there are more complications in the microaxial flow pump is that patients live long enough to experience them. But I think this is also consistent with our own clinical experience, which is that there is a higher risk of complications when using the large bore Impella device, but it does seem to save lives. And what's important here, I think, is that many of us are weaning these devices much faster than they did in the DanGer Shock trial. In the DanGer Shock trial, the protocol called for P9 for at least 48 hours. I don't think any of us are really doing that. I think we're trying to rapidly wean these devices and get them out. So I suspect that our complication rates in clinical practice may actually be less than this. But because of the DanGer Shock trial and the balance between the risk and the benefit, we gave the microaxial flow pump a 2A recommendation for use in selected patients with STEMI and severe or refractory cardiogenic shock. This is the first mechanical circulatory support device that gets a recommendation in the guidelines that's something other than a class 3. And class 3 is what the routine use of balloon pump and VA ECMO get. And this is why I wanted to talk to you about how these prior recommendations need to get carried over. The class 3 no benefit for IABP and VA ECMO were both in the 2021 revascularization guidelines. And because there have been no new trials to refute the findings of IABP Shock 2 trial as well as ECLS Shock trial, we couldn't really change these recommendations. I recognize that as a clinician, we all have patients who do better with a balloon pump. They turn around. We have patients who've walked out of the hospital after getting VA ECMO. The challenge here is who those patients are and how do we select them. And that's why the wording of this recommendation is very, very important. It specifically says routine use of balloon pump and routine use of VA ECMO, which I don't think any of us are really doing. We're selecting these patients carefully. I think the balloon pump patients are probably SCAI stage B. They're about to go into shock, but revascularization and balloon pump may pull them back from the brink. But this is really where you have to apply your clinical judgment. And I think that we got it right by saying that routine use really has no benefit. Whether or not the balloon pump has a benefit in danger shock like patients really is an open question. And it may be that as a community, we need to repeat all the shock trials and use the danger shock criteria, although trying to get those trials funded will be quite a challenge. The other new recommendation is on intracoronary imaging guidance for PCI. And the 2021 guidelines for revascularization, intracoronary imaging got a class 2A recommendation. And we took a fair amount of heat for that from the REVAS guidelines because everyone said, well, everyone's pushing intracoronary imaging. Why isn't it a class 1? Well, interestingly, in the 3 years between the 2021 revascularization guidelines and when we started writing the ACS guidelines, there were 3 trials published of intracoronary imaging, 2 of which showed a reduction in mortality. So now I think we have strong data to upgrade the intracoronary imaging guidance recommendation. This is a meta-analysis by Greg Stone. When you look at intravascular ultrasound versus angiography, IVUS is better. When you look at OCT versus angiography, OCT is better. When you look at both of them versus angiography, even though the confidence interval crosses 1 here, the point estimate favors imaging. And there's really no significant difference between OCT or IVUS. So in the revascularization guidelines, we have to be faithful to the trials. The trials looked at complex lesions. We worded this to say, for coronary stent implantation in the left main or in complex lesions, intracoronary imaging with either IVUS or OCT gets a class 1 recommendation. I recognize that we really should be using imaging for all PCI, even if it's non-complex. But again, we have to be faithful to the trials. And so the wording is specifically in complex lesions. Now, this is one of my favorite things. I'm glad Jeff is on the line. He gets so much credit for this. This is really Jeff's magnum opus, I would say. The MINT trial, I was privileged to work with Jeff on this study. 3,500 patients. This is an NIH-funded trial looking at patients with STEMI or NSTEMI who have a hemoglobin less than 10, who then got randomized to a restrictive transfusion strategy versus a liberal transfusion strategy, 2 different hemoglobin values, 8 versus 10, looking at 30-day death or recurrent infarction. This trial was very challenging to do for a couple of reasons. First of all, it occurred during COVID. But the second thing is that, patients don't stay in the hospital long enough to get anemic anymore. So think about the MI patients that you have who are anemic. They tend to be very elderly. They've got a lot of comorbid conditions, renal failure, et cetera. All of those patients were allowed into this trial. And really, a tremendous amount of credit goes to the sites that continue to enroll and get this trial done. And I think all of you are probably aware, we just barely missed sort of conventional statistical significance, but all of the point estimates suggest that a liberal transfusion strategy is beneficial in terms of 30-day death or MI compared with a restrictive strategy. And I want to give Jeff credit for choosing the color scheme here. I think in the interest of maintaining, peace in the United States, he actually colored the liberal red and the conservative blue, which is great. But this trial really was a win, I think, for the liberal strategy of transfusion. Although we didn't meet conventional statistical significance, there was a significant reduction in cardiovascular death, but it is important to note that that was not an adjudicated endpoint. So what we did was, I think that we got this right in the guidelines. We gave this a class 2B recommendation. The use of blood transfusion to achieve a hemoglobin level of 10 or greater may be reasonable to reduce cardiovascular events. And this, I think, is a bedside decision that we have to apply our clinical judgment when we're faced with an ACS patient who's anemic. Now, the other huge new set of recommendations are really around discharge antiplatelet therapy. And it seems like every week there's a new trial looking at so-called de-escalation of potent antiplatelet therapy. Now, what is de-escalation? Well, de-escalation can take multiple forms. You can shorten the duration of DAPT. You can de-escalate the potency of the P2Y12 inhibitor from ticagrelor, prasugrel to clopidogrel. You can change to single antiplatelet therapy and use a P2Y12 inhibitor instead. So these are all different combinations and permutations that have been studied. But in a patient in whom you're not worried about the bleeding risk, the foundational strategy that was recommended in the guidelines is still 12 months. And that's based on the randomized trials of dual antiplatelet therapy that looked at a 12-month strategy. So if you're not worried, all things being equal, really a patient with acute coronary syndrome should be treated with 12 months of DAPT. But there are some strategies you can implement to reduce bleeding risk. And the two class 1 recommended strategies are to use dual antiplatelet therapy with aspirin and ticagrelor, and then at 1 to 3 months, drop the aspirin and continue the ticagrelor strategy. This is the Twilight trial, the Global Leaders trial strategy that's been used here. The other is in a patient who has a clinical indication for oral anticoagulation. So a patient with AFib, for example. Several randomized trials now, 3 or 4, that have looked at dropping the aspirin and continuing with the P2Y12, mostly clopidogrel, plus the oral anticoagulant. This has shown a significant reduction in bleeding, really non-inferior with respect to ischemic events. There's one endpoint though that is increased, and that's stent thrombosis. So the question is, when do you stop the aspirin? These trials looked at, stopping it immediately before hospital discharge versus continuing for 4 weeks. Our recommendations are based on a post hoc analysis of the apixaban trial that suggested maybe 2 weeks is probably the right sweet spot for triple therapy as long as the patient is not at very, very high bleeding risk. So we said 1 to 4 weeks post PCI. There are some other strategies to get a class 2 recommendation. You can de-escalate the potency of the P2Y12 inhibitor, or you can stop the aspirin or the P2Y12 and go with single antiplatelet therapy. One of the things that we were charged with originally when we wrote these guidelines is to determine when does an ACS patient become a CCS patient. In other words, when is that risk period of ACS done and you can actually treat that patient as if they have stable ischemic heart disease? Well, we decided to face that challenge head on by not facing it because I don't think we know the answer to that. And as a writing committee, we said, look, we can't make a recommendation on this because it's probably different from each patient. Some patients may, in fact, be at higher risk continually beyond a year. Others may stabilize, and that may depend on residual coronary disease. It may depend on their other risk factors. So we don't really know when a patient transitions from ACS to CCS. What we do recommend is that ACS patients be treated with a foundational strategy of at least 12 months if they don't have high bleeding risk. All right, let's go back to our patient. Remember, we're getting graded pretty well here, class 1 across the board. Well, I'm going to work up her anemia and give her a transfusion. That's a class 2B. I was involved in the MINT trial, so I'm going to give myself a break, and that's a class 2 recommendation, but I'm still fine with that. If this patient undergoes PCI, then we're definitely going to use intracoronary imaging. That's a class 1 recommendation. If she has multivessel CAD, then I'm going to punt, and I'm going to enroll her in the COMPLETE 2 trial so we get some answers. All right? So what did we borrow from recent guidelines? Well, as I mentioned to you a couple of times, there were the 2021 revascularization guidelines, and we borrowed a couple of recommendations from them. The first is radial access. For the first time, radial approach was included in the 2021 revascularization guidelines. The benefit of radial access is augmented in the ACS population, particularly in STEMI patients, where it has shown a reduction in mortality. So we say that a radial approach is preferred to femoral approach to reduce bleeding, vascular complications, and mortality. That's a class 1 recommendation. The other thing that we carried over from the REVASC guidelines is what do we do with non-culprit disease in a patient in shock? Now, I talked to you about the STEMI patient who's stable, but what about a patient in shock? From a mechanistic standpoint, it kind of seems to make sense to treat all the culprit disease in addition to the other non-culprit disease in a patient in shock because, their pump dysfunction, their LV is failing, so we treat the infarct artery. Maybe the other areas are ischemic and we should treat those too. And some observational data suggested that might be the right thing to do. But the culprit shock trial showed exactly the opposite. In this trial, multivessel PCI at the time of primary PCI resulted in worse death, worse renal failure, and worse bleeding. So this was taken into the revascularization guidelines, and we ported that into the ACS guidelines. We said if you've got a STEMI with multivessel CAD and you're in cardiogenic shock, routine PCI of the non-infarct-related artery at the time of primary PCI should not be performed. That's a class 3 recommendation because of harm. Now, when these patients stabilize and their shock state is resolved, that's when really the non-culprit disease should be addressed, but it really should not be done at the time of primary PCI. All right, so here's our patient's treatment. What did we do? We took her to the cath lab. We used left radial access. There's a relatively straightforward mid-LAD lesion that's significant, and we went ahead and stented it using IVUS guidance, and I think we got a very, very acceptable result. So are we done? No, absolutely not. We've got a lot of things left to do for this patient because we want to prevent her from coming back to the hospital. So for many of these patients, this is the first time, their ACS presentation is the first time they've ever been diagnosed with heart disease. So they need a lot of education. When can they go back to work? When can they travel? When can they start exercising? What about secondary prevention? Incredibly important to make sure that they have their lipid lowering therapy, their diabetes is under control, the smoking cessation, et cetera. Cardiac rehabilitation gets a class 1 recommendation in the guidelines. So what did we do? We gave her a discharge antiplatelet therapy with a P2Y12 and a DOAC. Remember, she had AFib. That's a class 1 recommendation. And then, of course, we make sure that we get her lipids down as low as possible. That's aggressive secondary prevention, and that gets a class 1 recommendation as well. I want to start wrapping up here with some selected comparisons with the ESC guidelines. The European guidelines came out before ours. We're all looking at the same body of data, and yet there is a slight difference in interpretation. For example, the ESC combines the timing of non-infarct-related artery, the recommendation for non-infarct artery PCI, and the timing into one class 1 recommendation. We actually gave it 2 separate recommendations. The ESC parses the timing of non-infarct artery in shock, whereas we did not. We just put it into the text. They gave it a 2A for stage. The ESC also gives a class 2A for non-infarct-related artery PCI and NSTEMI, while we gave it a class 1 recommendation. The ESC specifically gives preference to practical over ticagrelor based on the ISAR React 5 trial. We elected not to do that. We said that the ISAR React 5, which is a perfectly important study and well done, it is unblinded and it's only one trial, so we thought that more potent P2Y12 is better than trying to parse these two things. The ESC does not give ticagrelor monotherapy after 1 month, a class 1 recommendation, whereas we did. And then the ESC provides specific guidance on the duration of triple therapy for patients requiring oral anticoagulation. As I mentioned to you, we just said 1 to 4 weeks. We put that in the text. They actually gave it a recommendation, class 2A, for 1 week to 1 month. ESC specifically calls out an LDL target of less than 55. We said that if your LDL is 70 and you've had an ACS, you should go lower. We didn't call out 55 as a target. I think the lipid lowering guidelines may do that when they get published. And then the ESC specifically calls out PCSK9 inhibitors. We use the term non-statin alternatives, including ezetimibe, based on the A to Z trial, which is specifically an ACS trial. PCSK9 inhibitors have not been specifically studied in ACS. Lots of things to study still. I think there's a reason why we continue to do trials. We're looking at best use of mechanical circulatory support devices. Complete 2 trial I talked to you about. When can we discharge these patients? Do they really need to be monitored for a couple of days, or if they've had successful IVUS-guided PCI, can they be sent home? These are all things that I think we're continuing to study and will inform the guidelines. I want to end on a quick note because I think it's important that we continue to discuss and critique the guidelines. One of the critiques that was levied at the 2014 NSTEMI guideline was that there were only 15% of the recommendations that were level of evidence A. In my mind, that's not a critique of the guidelines, it's really a critique of our profession. And I'm glad to say that our profession has continued to do randomized trials. Now, 27% are the highest level of evidence, and 66%, 2/3 of the recommendations in this document, are based on randomized trials. That's really, I think, an important thing and probably well ahead of most other clinical specialties. So to summarize, the 2025 ACS guidelines are really a good evidence summary document. It summarizes the evidence base to improve outcomes. It's the first update in 12 years to include contemporary randomized trials across the treatment spectrum for both NSTEMI and STEMI. But the foundational strategies are still the same: antiplatelet therapy, antithrombin therapy, and invasive risk stratification. What's new is how do we treat multivessel disease, guidance on how to deal with anemia, intercoronary imaging, cardiogenic shock. And the ground is shifting beneath our feet. I mean, this is the 15 minutes of fame this document's going to get, because this is most certainly going to be updated with new randomized trial evidence. But in the meantime, our challenge is implementation, making sure that we apply these guideline-based recommendations at the bedside. And we need to leverage our EHR, I think all of us are trying to figure out how best to use AI so we're not missing patients who are just languishing in the ED with no treatment, and yet they have ACS. So I think this is going to be a really, really exciting area. I really want to thank my vice chairs, Michelle O'Donoghue and Mark Rule, who were really instrumental in this, as well as the ACC and the AHA staff. And of course, the writing committee, who worked really hard to bring this in on time. And then I want to thank our peer reviewers who kept us honest throughout the entire writing process. I also want to thank all of you for inviting me. Again, I wish I could be there in person, but I really appreciate the invitation. I'm very honored by it, and I hope that you'll share some questions or comments about the ACS guidelines. So thank you very much.
Thank you very much, Sunil. That was an excellent overview. And first of all, congratulations for the tremendous amount of work you and the team has put together to bring this. It's a Herculean task. And I know that the scientific community always have critiques and elements of consolations that we are always looking for. But to put this all together, I really want to make sure that people understand how much of work it goes behind, and also is a testament to the way the committee is trying to shepherd the direction. So this is a great effort, and thank you very much. And you covered it so wonderfully in the amount of time that was allotted. I do have a few questions, and I would
Sure.
like to encourage some of our colleagues to they can unmute and ask in the chat, whichever way they feel is easier. Let me first ask it started off with the idea of type 1 and type 2. Is this
Yes.
so gray? Is this black and white or is this gray? The reason is the coronary erosion and
Yeah.
the tsunami of non-STEMIs and what we call as non-obstructive coronary artery disease, which are erosions, but they are eventually
Yeah.
almost like type 1, but they could be misdiagnosed as type 2 and may not get some of these targets that you are looking at. How do you handle it, given the information that STEMI is going down, the amount of non-STEMI is increasing, and a
Yeah.
very large proportion of these are all this opaque phenotypes?
Yeah, it's a great question, and I think type 2 is still a diagnosis of exclusion. And I think that we're getting smarter, and that maybe even our lexicon is changing a little bit. When we see a patient with an elevated troponin who may not have a classic story, we start talking about myocardial injury rather than MI, or myocardial infarction. And the reason I think is that we now recognize that there are multiple reasons why that high sensitivity troponin is elevated, and that's what we talk to patients about. We say, the reason that we still tend to do invasive risk stratification in these patients. And when we talk to them about their cath, we tell them the reason we're doing this is that we want to determine whether or not you're actually having a heart attack, or if this elevation in this marker that we're picking up in your blood is from some other reason for myocardial injury. But the challenge for the ACS Guidelines Writing Committee is that there really aren't any great randomized trials in type 2 MI. And so how we treat them is really, I think, dependent on the clinical context. For many of these patients who have a good reason, let's say, to have some kind of supply-demand mismatch, we generally tend to treat them as type 1s, right? We take them to the cath lab. We tend to stent significant lesions. Are we reducing their risk? I don't know the answer to that. We think we are, right? Because we think it's the same process. Similarly, for Minoka, which is mentioned in the chest pain guidelines, but not in this guideline, what is the right treatment for that? I don't really know. I mean, microvascular dysfunction clearly accounts for some of those Minoka patients, but do they have platelet activation? Is antiplatelet therapy the right thing? We didn't feel like we had enough data to actually make strong recommendations in that space, and which is why we left it out. And I look forward. Hopefully, there will be some trials. I know that SCAD, for example, is a great example. Jackie Saw and Roxana Moran have submitted to the NIH to do a multinational study of antiplatelet therapy in SCAD. In some ways, that makes sense, right? That antiplatelet therapy might be the right thing. In other ways, it doesn't. SCAD is on the same spectrum as Takotsubo. Is it really a mechanical dysfunction rather than a platelet one? And so these are really exciting times, and that's why I said that this document is going to be rapidly outdated because of the evidence base.
And your assertion on coronary imaging is also very important because it gives you fascinating information. Let me ask you, what are your takes? Many times, I mean, we know that we see the troponin rising. We take looks like non-obstructive, but then I'm seeing something hazy, and then I'm seeing a thrombus. Are you going to leave it, do a thrombosection, even if it's not occlude? Maybe that's still the story of type 1, but it's not yet completely
Right.
clear which way we will go.
Yeah, yeah.
But we see that off happening all the time, and the knee jerk is that you end up getting a stent, right? I mean,
Right. Yeah, and I was just going to say that. I mean, look, my day job, I'm a knuckle dragging interventionalist, right? And when I take a patient to the cath lab and I see something that's disrupted, I see something that's thrombotic, I feel like, that's an unstable plaque. We really need to treat that. Again, the long-term consequences of that, I'm not really sure. But I do think that in those situations where we're seeing some kind of disruption, some kind of hazy looking lesion, thrombus with intracoronary imaging, and we see plaque rupture, we feel like that's a thrombotic milieu, and really stenting is probably the right thing to do.
perfect. And then I'm going to there's a questions coming up, but I'm going to
Yeah.
ask you also. You briefly touched upon this whole paradigm of occlusion MI. So
Yeah.
I'm sure that you must have had sufficient time to discuss of how to deal with this because there's
Yeah.
more and more literature. But I think the term occlusion MI, I believe, is not an AI diagnosis. It's more of a phenotype that we miss,
Yeah.
right?
Right.
So and it's something where people are getting delayed. So having not dealt with within the guidelines yet,
Yeah.
what do you see is the near future going to be about that?
Oh, I think the future is now. I mean, I'm sure you're doing this. We're doing this. We're deploying AI models across our EKGs to make sure that we're not missing this. I actually think that if you look, and this is um, uh, not definitive, but I'm speculating here. I suspect that many of the early deaths or the early recurrent MIs in the large randomized trials of ACS and the patients who drove those endpoints, some of those patients may have been circ infarcts, right? Because
Hmm.
they're electrocardiographically silent. They were called NSTEMIs. And when they went to the cath lab, they probably had an occluded circ branch or an occluded main circ. Those are really STEMIs. And really, I think that's what we're missing. And I think that we're going to get to a point, I would suspect, probably within the next 12 months across most places, where we're deploying models, whether that's with EKGs, whether that's with POCUS, some other serum mark, something that's going to tell us that this patient is not someone that you can kind of give antiplatelet therapy to, put them on the cath lab schedule for the afternoon, but you really need to get them into the cath lab right now. And I think it's going to help us because as a cath lab director, one of the things I struggle with is how do I accommodate these patients? How do I triage these patients? And if I
Yes.
can be told, look, there's a high probability this patient is actually having a STEMI that's electrocardiographically silent, I'll know that that patient needs to go right now.
Yes. So let's get to the some of the questions. I think Dr. Kama Muganti is asking two questions. How
Yeah,
is intracoronary imaging being used in ACS? I mean, I think maybe you've touched upon that. Should patient be getting OCT versus FFR for
yeah,
non-culprit lesions? And then
right.
the second one is a SCAD patient still baffle us from intervention to therapy. What is your take?
Yeah, great questions. I think that in the ACS space, for whatever reason, maybe we're not smart enough to figure out, FFR does not seem to necessarily be the appropriate strategy. And I'm saying that specifically about STEMI. Now, in NSTEMI, remember, there were some NSTEMI patients included in the FAME trials. So it's a little bit less of a definitive thing in the NSTEMI space, and which is why we're doing Complete 2, is to sort of figure out the definitive answer to that. The FAME trials had patients who had stable ischemic heart disease and NSTEMI, so it's a little bit of a mishmash of patients, so it's hard to tease out. But my personal view is that if you've got a patient who clearly has an NSTEMI, they don't have a thrombotic lesion, they've got non-culprit disease, if it's moderate, then what we're generally doing is we are doing physiology on them, and that's a class 2 recommendation. My take on the intracoronary imaging versus physiology debate is that the only thing that intracoronary imaging seems to provide over physiological assessment in the stable ischemic heart disease patients is more stents. Not a better outcome, just more stents. So I think we have to be a little bit careful about sort of overusing intracoronary imaging for diagnostic purposes, in the sense that we're using it to have a go no go decision about PCI. I think still physiology probably reigns supreme there. Now, diagnosis of SCAD, diagnosis of plaque erosion, it's still a lot of value there. And I agree with you. I'm puzzled by SCAD patients. I'm glad that we don't have to do PCI in them, except in selected cases. But they are, I think, a population that we really need to study because they tend to be active people, right? I remember very clearly a competitive CrossFitter, female CrossFitter who was 35, who had multi-vessel SCAD. And we had to have a very difficult conversation with tell her that we don't think you can do CrossFit anymore. And this is how she identifies, right, as a CrossFitter, right? So these are difficult conversations to have, and I hope that we get more data. I see that Ramzan is asking a great question, which is, culprit shock was a randomized trial of non-culprit PCI versus culprit PCI only. In the danger shock trial, there was a post hoc analysis, which is really an observational analysis, suggesting a benefit for non-culprit PCI. I think, I wrote the editorial for that particular analysis in Jack Interventions. And I think there are a couple of things that we have to think about, which is number one, it's an observational analysis, which is it's almost certainly confounded. The second thing is that the benefit of non-culprit PCI in that post hoc analysis was greater than the benefit of the microaxial flow pump, which is the actual randomized treatment assignment. So I think it suggests that there's a lot of selection bias there. Having said that, though, I do think that we need to, as a community, start thinking about whether we need to revisit some of these sacred things in the shock population and repeat some of these trials in a danger shock-like population. My sense is that some of these strategies that we've relegated to the class 3 bin are probably going to end up in the class 2 bin, maybe even the class 1 if we were to repeat these trials. But again, funding of these trials is going to be very, very challenging. And even if we do get them funded, as a clinical community, we have to be willing to randomize those patients. So yeah, great question, Ramzan.
And then, Sunil, I wanted to also ask you, South Asians
Yeah.
and premature coronary artery disease. I often see this debate about the. I think we talk about the 70, but I think we know that the 70 may be a number which may be
Yeah.
a large, much higher number for some of these
Right.
phenotypes. How do you then reconcile? Because I think we are seeing some other guidelines coming up which are even
Yeah.
more aggressive.
Yeah.
Should it be ethnically or phenotypically driven, or should it be one go all for
I
everybody?
would love to have something that's more individualized. I don't think we have enough data yet. I do think that lower is better, and I think that 55 or less is probably the target. Again, we had to wrestle with the fact that there are no great ACS trials specifically looking at that target. And so we're kind of bound, like the Supreme Court is to precedent, right? So we have to, based on the available evidence. But I think, again, that evidence is rapidly changing. I mean, well, you'll notice that LP little a was not included in the ACS guidelines either. And I think many of us are checking the LP little a. Whether we have treatment strategies to lower that remains to be seen. But I think lower probably is better. And until we have more data, I would apply it to everybody.
Fantastic. I think I'm seeing another question from Dr. Ashok Chaudhary.
Yeah.
Your take on prasugrel over tecagrel are of practical consideration, cabbage, wait time, etc.
Yeah, so I think that the evidence is starting to emerge now, based not just on ICER React 5, but my colleague Sripal Bangalore presented the Tuxedo 2 trial at the AHA. It's not in press yet. I think that the data are emerging that prasugrel, in fact, probably is superior to ticagrelor. The problem with prasugrel, as you all know, is that there are some black box warnings. I mean, relative contraindications based on age and body weight, and an absolute contraindication based on prior stroke. So I think we have to we use more prasugrel now. It is generic, but we are being a little bit careful about those contraindications. And regarding those contraindications, what if the patient's 74? They're not 75 yet. They turn 75 next month. Should I still use it? I mean, these are the kind of nuances that you get into. So we tend to use prasugrel in kind of the younger patient, the patient who clearly is robust. And that's where we're really kind of using prasugrel.
Thank you. Dr. Maya Guglin, our section chief for advanced heart failure, is raising a hand. And Maya, please go ahead.
Hey, Sunil, great presentation, great guidelines. Thank you. The question is, of course, about the Impella CP in the setting of cardiogenic shock with MI in the cath lab. First question, you put 2A indications in the guidelines. Did you change your personal practice? Do you always put CP under these circumstances? Number two, based on the results on the danger shock trial, other trials were shut down because the reading was we already have enough evidence. Why to do more trials? And if you look at some alternative metrics like fragility index, there were only 4 patients that
Right.
changed the outcomes of this trial. So I don't remember any other case in the history of cardiology, if you allow me,
Mm.
when the guidelines were changed based on the outcomes of 4 patients. Do you feel strongly that this was the right move?
Yeah, thank you, Dr. Goodwin. It's great to see you, and thank you very much. So I'll answer the second question first. I do think we got it right this time. I think fragility index is just another way of rephrasing the p-value, right? So, and I think at the end of the day, these are speculative things. What if this had happened? Well, at the end of the day, it didn't happen, right? So I think we got it right. I don't think it rose to the level of class one for the reasons that you indicated. So 2A, I think it can be considered, and that's the language that's used. Our personal practice has changed. Now we are still very selective about who gets an Impella CP in shock. Our shock protocol changed to reflect the inclusion and exclusion criteria that were used in danger shock. And one thing that we don't do is, again, we don't use the same weaning protocol that was used in the danger shock trial. That weaning protocol is actually available as a supplement. We tend to wean the Impella CP much, much faster. So yeah, I do think that it's an important trial. It has changed our practice. But again, we are being very selective about who gets an Impella CP with shock, really based on the danger shock inclusion exclusion. There are parts of the country, as you know, must be something in the water in Detroit. Everybody with shock gets an Impella CP, but that's not certainly our practice.
Thank you.
And Dr. David Scher is asking a question about antithrombotic therapy post-MI of the first year, aspirin versus monotherapy versus
Yeah.
continued DAPT in selected patient versus aspirin and low-dose rivaroxaban.
Yeah, terrific question. Thank you for that. We wrestled with this, and I think it's safe to say that our recommendation is likely outdated. I mean, look, I can't speak for what the next set of guidelines are going to say, but there have been a couple of trials now looking at aspirin versus P2Y12 monotherapy, what previously was considered to be an unethical trial. I mean, many of you are old enough to remember the old Capri trial. Remember that? 1991, I think, or two, where patients were randomized. These are high-risk secondary prevention or high-risk primary prevention, mostly secondary prevention. Patients randomized to clopidogrel alone versus aspirin alone. Clopidogrel was the winner in that trial, P of 0.04 for cardiovascular death, MI, or stroke over the long term with no increase in bleeding. And at that point, basically, everyone said, well, aspirin is still foundational therapy for MI. It's unethical to randomize someone to getting no aspirin. But that's actually what's happened now. And there have been a couple of trials that have suggested that P2Y12 monotherapy is superior to aspirin. So I think that the guidelines are going to have to consider that, these new trials that we just didn't have time to consider. Our own personal practice is changing. We're starting to treat patients with a lot more P2Y12 monotherapy now when that period of risk is over rather than going with aspirin. The question about low-dose rivaroxaban is a great one, and we wrestled with this. This was a struggle for us because this is the Atlas trial looking at low-dose rivaroxaban that showed a benefit. The challenge I think that we ran into was that follow-up in that trial was really incomplete. There were a lot of patients who were lost to follow-up, so it's very difficult to actually interpret what that really means when you have such a large loss to follow-up. In fact, that was one of the reasons why the FDA didn't grant the indication for rivaroxaban in that population. So we decided not to include it in the guidelines because we didn't feel like the level of evidence rose to that level. And the uptake of rivaroxaban has been very, very slow for reasons that are not clear to me. I mean, COMPASS, for example, which is kind of the secondary prevention trial, not an ACS trial, is a very, very positive study. But there seems to be some kind of bias that cardiologists have against oral anticoagulation in the absence of atrial fibrillation or a mechanical valve. And maybe that's a hangover from the old Coumadin trials or something like that. But I do think that in certain populations, low-dose rivaroxaban is very, very beneficial in terms of clinical outcomes. In ACS, I'm still not convinced yet, and which is one of the reasons why we didn't include it in the guidelines document. But yeah, great question.
And Sunil, the last question I would like to ask, and I think we are driven by the evidence that comes from randomized clinical trial, but I think we know the sometimes the limitation of how the trials are designed and the endpoints are adjudicated, or even the complications are lumped together. For example, an intracerebral bleed do we weigh it differently than any other type of bleedings? I mean, probably not. We lump them all together in the same category, and yet when we apply it, you're encountered with a 80-year-old elderly person, and you're wondering whether the person is going to bleed, or it's more challenging. So how do you really talk about guideline than translating it into a clinical judgment?
Yeah, yeah,
And
it's very
and that
challenging.
piece nobody teaches because we talk about implementation of guidelines, and I think we do a great job, and we have done a great job. But the conversion to uh, making it more impactful, what do you talk about that? How do you do that?
Yeah, it's a great question, and it's really the most important one, I think, is what you're asking. And I guess all I have to say is that I don't think AI is going to replace us just yet. Okay, as cardiologists, I mean, I'm glad to say there's still room for clinical judgment. My own personal opinion, and I'm not speaking on behalf of the ACC or the AHA, is that the guidelines really should be class one and class three. I think class two is all clinical judgment. And I think we spend a lot of energy and time and sweat arguing over 2A versus 2B. And it's just a difference between maybe considered or is reasonable. And I sit back and I think, are we really spending all this time looking at 2A versus 2B? That's really up to the clinicians at the bedside who's evaluating the patient. So I think that that's the important thing. And I want to drive that home because otherwise, AI could do all this just by implementing the guidelines in the EHR. But I think patients deserve more than that because they are individuals. And I think that when we interact with them, we get information that the guidelines simply don't have. And that's really where the application is important.
Perfect. With that note, I want to thank you and I want to thank everyone for joining us in, and we look forward to having you in person, perhaps very soon.
Thanks so much, Arthur. Great to
Thank
see
you very
everyone
much.
again. Thank you for the
Take
invitation.
care. Bye-bye.
Bye bye.
Good night.